Ventral hernias introduction and anatomy. Welcome to today's podcast, where we discuss the management of ventral hernias in a formal question and answer format. Each question is followed by a complete answer to support medical students, surgical residents, clinicians, and other listeners interested in abdominal wall surgery. Pause after each question if you would like time to answer before continuing. Let us begin. Question: what is a ventral hernia? Answer: a ventral hernia is an anatomic defect of the anterior abdominal wall that leads to the herniation of preperitoneal or intraperitoneal contents. Question: what are the main types of ventral hernias? Answer: the main types are spontaneous hernias, such as umbilical and epigastric hernias, and acquired hernias, such as incisional and traumatic hernias. Question: what are incisional hernias? Answer: incisional hernias are the most common acquired type of ventral hernia. They occur in approximately 12% of major open abdominal surgical incisions and 3% of minimally invasive operation incisions. Question: how common is ventral hernia repair? Answer: ventral hernia repair is a common surgical procedure, with rates exceeding 600,000 in the United States between 2006 and 2016. Question: how has ventral hernia repair evolved? Answer: ventral hernia repair has evolved with the development of new materials and minimally invasive techniques, although recurrence rates remain high. Question: what is the goal of ventral hernia repair? Answer: the goal of ventral hernia repair is to achieve a durable repair and restore abdominal wall anatomy while minimizing complications. Question: what are the layers of the abdominal wall from anterior to posterior? Answer: from anterior to posterior, the layers are skin, subcutaneous tissue, superficial fascia, deep fascia, muscle, transversalis fascia, preperitoneal fat and areolar tissue, and peritoneum. Question: what are the types of ventral hernias? Answer: the types of ventral hernias include spontaneous hernias, such as umbilical and epigastric hernias, and acquired hernias, such as incisional and traumatic hernias. Question: what are the features of superficial fascia composition? Answer: superficial fascia is composed of Camper's fascia and Scarpa's fascia. These layers are fused above the umbilicus and become distinct below it. Question: what are the characteristics of Camper's fascia? Answer: Camper's fascia is continuous with the superficial adipose tissue, varies in thickness, and extends inferiorly with the superficial fascia of the thigh to the scrotum or labia majora. Question: what primarily forms the anterior abdominal wall? Answer: the anterior abdominal wall is primarily formed by the rectus abdominis muscles and their fascia, including the anterior rectus sheath and posterior rectus sheath. Question: what is the linea alba? Answer: the linea alba is the midline fusion of the bilateral rectus abdominis fascia, extending from the xiphoid process to the pubic symphysis. Question: what forms the lateral abdominal wall? Answer: the lateral abdominal wall is formed by the external oblique, internal oblique, and transversus abdominis muscles, each with its own facial covering. Question: where is the arcuate line located? Answer: the arcuate line is located midway between the umbilicus and the symphysis pubis. Question: what is the anatomical significance of the arcuate line? Answer: the arcuate line marks the transition in the composition of the posterior rectus sheath. Question: how does the composition of the posterior rectus sheath change above and below the arcuate line? Answer: above the arcuate line, the sheath includes the external oblique aponeurosis and the internal oblique aponeurosis. Below the line, it includes the external oblique, internal oblique, and transversus abdominis aponeuroses. Question: what are the lateral abdominal muscles? Answer: the lateral abdominal muscles are the external oblique, internal oblique, and transversus abdominis muscles. Question: what are the features of the external oblique muscle? Answer: the external oblique muscle originates from the lower 8 ribs, inserts into the pubic crest, and contributes to the formation of the inguinal ligament. Question: what are the features of the internal oblique and transversus abdominis muscles? Answer: the internal oblique originates from the thoracolumbar fascia and iliac crest, while the transversus abdominis is the deepest layer and originates from the iliac crest, inguinal ligament, and lower 6 costal cartilages. Question: how is the blood supply of the abdominal wall organized? Answer: the blood supply of the abdominal wall is divided into 3 zones. Question: what supplies zone I of the abdominal wall? Answer: zone I is supplied by the superior epigastric artery and the deep inferior epigastric artery. Question: what supplies zones 2 and 3 of the abdominal wall? Answer: zones 2 and 3 are supplied by the epigastric arcade, the superficial inferior epigastric artery, the superficial external pudendal artery, the superficial circumflex iliac artery, the musculophrenic artery, the lower intercostal arteries, and the lumbar arteries. Question: what structures are supplied by the superior epigastric artery and the deep inferior epigastric artery? Answer: both arteries supply the rectus abdominis muscle, the subcutaneous tissue, and the skin. Question: where are the superior epigastric artery and the deep inferior epigastric artery located? Answer: both arteries are located posterior to the rectus muscles. Question: how do the superior and inferior epigastric vascular systems behave within the rectus abdominis muscle? Answer: these 2 vascular systems branch out and converge within the rectus abdominis muscle between the xiphoid process and the umbilicus. Question: what is the blood supply source for the lateral abdominal wall? Answer: the blood supply arises from the musculophrenic artery, the deep circumflex iliac artery, and branches of the lower intercostal and lumbar arteries. Question: where is this blood supply located in the lateral abdominal wall? Answer: it is located within the plane between the transversus abdominis and internal oblique muscles. Question: what is the source of nerve supply to the abdominal wall? Answer: the nerve supply comes from branches of the intercostal nerves from thoracic level 7 to lumbar level 1. Question: what provides motor innervation to the abdominal wall? Answer: motor innervation is supplied by thoracic level 7 to thoracic level 12 intercostal nerves, as well as the iliohypogastric and ilioinguinal nerves. Question: why is preservation of the neurovascular bundles clinically significant? Answer: intraoperative identification and preservation of the neurovascular bundles are crucial because injury may lead to rectus abdominis muscle atrophy and damage to the linea semilunaris. Management of ventral hernias diagnosis. Question: what should be explored in the patient history when evaluating a ventral hernia? Answer: the patient history should explore risk factors, symptoms, effects on quality of life, and surgical history, including details of previous hernia repairs and mesh placement. Question: what should be assessed during the physical examination of a ventral hernia? Answer: the The examination should note surgical incisions, assess abdominal wall asymmetry while the patient is standing, and evaluate facial defects and abdominal wall weakness using the Valsalva maneuver and a straight leg raise while the patient is supine. Question: when is imaging necessary, and how should ventral hernias be classified? Answer: computed tomograph imaging is necessary for complex presentations, and the European Hernia Society classification is recommended for clinical documentation. Open approaches to ventral hernia repair. Question: how far back does the history of hernia repair extend? Answer: the first reports of hernia repair date back to the 4th century before the Common Era. Question: what is the goal of hernia repair? Answer: the goal is durable repair of facial tissue to prevent reherniation. Question: what are the principles of hernia repair? Answer: the principles are to restore native anatomy and distribute tensile forces effectively. Primary repair. Question: what is primary repair? Answer: primary repair is suture closure of a facial defect without mesh. Question: when is primary repair used? Answer: it is used for small, primary facial defects such as umbilical or epigastric hernias. Question: what is the main limitation of primary repair? Answer: primary repair has a higher recurrence rate than mesh repair and is generally avoided for incisional hernias. Question: how effective is mesh in umbilical hernia repair? Answer: mesh significantly reduces recurrence rates in umbilical hernias, especially those larger than 2 centimeters in diameter. Question: by how much can mesh reduce recurrence in larger and smaller hernias? Answer: for hernias larger than 2 centimeters, mesh reduces recurrence from 22% to 9%. For smaller hernias measuring 1 to 2 centimeters, the recurrence reduction is from 8% to 2%. Question: what type of study supports these findings? Answer: these findings are based on a randomized controlled trial. Question: what is a benefit of primary repair? Answer: a benefit is that it avoids mesh-related complications. Question: what recurrence trade-off must be discussed with primary repair? Answer: there is a modest increase in recurrence for smaller defects when mesh is not used. Question: how do mesh repair guidelines vary? Answer: mesh repair guidelines vary in the size cutoffs they use, ranging from 1 centimeter to 2 centimeters. Question: how can hernia risk be minimized during laparotomy closure? Answer: hernia risk can be minimized by using a small bites approach of 0.5 centimeters by 0.5 centimeters, with a 4:1 suture to incision ratio and a slowly absorbable suture. Question: how should small primary hernias be approached? Answer: small primary hernias can be repaired using various approaches, including mesh placement, which lowers recurrence risk but may not be preferred by every patient. Question: what should be covered in patient counseling? Answer: counseling should cover expected outcomes, the absolute risk reduction offered by mesh, and the potential for recurrence. Question: how long does facial healing take? Answer: facial healing is complex and may take more than 1 year to complete. Question: how much strength does fascia regain early after surgery? Answer: between the 8th postoperative day and the 2nd month. Facial strength increases to about 50% of its original strength. Question: what suture material is recommended for facial closure? Answer: a slowly absorbable suture is recommended so that closure does not fail before significant facial strength is regained. Question: what early primary closure techniques were used before mesh became common? Answer: before mesh, surgeons used several techniques with absorbable and non-absorbable sutures for primary closure. Question: what is the modified Mayo technique? Answer: the modified Mayo technique overlaps the facial edges with 2 separate suture lines, creating redundancy. Question: what is a keel repair? Answer: a keel repair uses the hernia sac to create posterior redundancy and may include relaxing incisions to reduce tension. Mesh repair. Question: what are the main types of mesh used in ventral hernia repair? Answer: the main types are permanent mesh and absorbable mesh. Permanent mesh is made from synthetic polymers such as polypropylene, polyester, and polytetrafluoroethylene, while absorbable mesh is designed to degrade over time. Question: what are the characteristics of permanent mesh? Answer: permanent meshes vary in weight, porosity, and hydrophilicity, and some may include anti-adhesive barriers. Question: what should be considered when comparing mesh weight? Answer: mesh weight comparisons should be made within the same material category, because ultra-lightweight meshes may have increased failure rates. Question: how are absorbable meshes classified? Answer: absorbable meshes are classified into biologic and biosynthetic types. Question: what are the characteristics of biologic mesh? Answer: biologic mesh is derived from human or animal tissue, is gradually degraded by the host, and is classified by source material, processing technique, and sterilization method. Question: when is biologic mesh commonly used, and why has its use declined? Answer: biologic mesh has often been used in contaminated cases, but its use has declined because of high recurrence rates and high cost. Question: what materials are used in biosynthetic mesh? Answer: biosynthetic mesh may be made from materials such as polylactin, poly-4-hydroxybutyrate, and polyglycolide trimethylene carbonate copolymer. Question: how long do absorbable meshes persist? Answer: depending on the material, absorbable meshes may persist from 2 to 3 months up to 18 months. Question: in what setting are absorbable meshes commonly used? Answer: they are commonly used in contaminated fields when facial closure is desired but permanent synthetic mesh is not appropriate. Question: what is an intraperitoneal underlay repair? Answer: it is a repair in which mesh is placed deep to the parietal peritoneum, within the intraperitoneal space. Question: what type of mesh is required for intraperitoneal placement? Answer: the mesh must either be coated with an anti-adhesion barrier or be absorbable so that it can safely contact the bowel. Question: how can intraperitoneal underlay mesh be placed? Answer: it can be placed either through a minimally invasive approach or through an open approach using transfascial fixation sutures. Question: what are the key steps in the open intraperitoneal underlay technique? Answer: the open technique uses a midline incision, complete reduction of hernia contents, and circumferential adhesiolysis before mesh placement. Question: why is mesh sizing important in this technique? Answer: precise mesh sizing is essential to ensure a proper fit and to avoid wrinkling or mechanical failure. Question: how much mesh overlap is generally recommended in open procedures? Answer: Answer. Although wide overlap has not been consistently linked to lower recurrence in open repair, a 5 cm overlap is still recommended. Question. How is the mesh secured in an open intraperitoneal underlay repair? Answer. The mesh is secured circumferentially with transfascial sutures that pass through the abdominal wall and along the mesh edge. Question. What should be considered after mesh placement? Answer. The surgeon should measure transfascial suture positions carefully to prevent mesh wrinkling and may consider subcutaneous drains to reduce seroma formation. Question. What are the advantages of the open underlay technique? Answer. It provides a mechanical advantage against outward intra-abdominal pressure and reduces the risk of contamination and superficial surgical site infection. Question. What is the main disadvantage of the open underlay technique? Answer. It has largely been replaced by sublay techniques because sublay repairs have better recurrence and surgical site infection outcomes. Question. What is retromuscular sublay repair? Answer. Retromuscular sublay repair is a technique in which mesh is placed deep to the rectus muscle and superficial to the posterior sheath, parietal peritoneum, and sometimes the hernia sac. Question. What is another name for retromuscular sublay repair? Answer. It is also known as the Rives stopper repair. Question. What are the advantages of retrorectus mesh placement? Answer. It avoids the need for coated mesh and places the prosthesis in a highly vascularized space that promotes integration. Question. What are the main operative steps in retromuscular sublay repair? Answer. The operation includes laparotomy, reduction of herniated viscera, lysis of adhesions, preservation of the hernia sac, identification of the rectus muscle, and opening of the posterior sheath at its medial attachment to the linea alba while avoiding iatrogenic injury. Question. How is the retrorectus space developed? Answer. The posterior rectus sheath incisions are extended cranially and caudally, and the retrorectus plane is developed laterally while protecting the neurovascular bundles. Question. How extensive should the dissection be? Answer. The dissection should extend at least 5 cm superior and inferior to the defect, and it may continue to the diaphragm superiorly and the space of retzius inferiorly. Question. How is the mesh sized and placed in retromuscular repair? Answer. Surgeons aim for at least 5 cm of overlap from the defect. The mesh is typically sized to occupy the full retrorectus space, trimmed to fit, laid flat against the posterior layer, and fixation is optional. Question. How is closure performed in retromuscular sublay repair? Answer. The posterior sheath, the hernia sac when needed, and the anterior rectus fascia are closed with absorbable suture. Question. How does sublay mesh placement compare with other mesh positions? Answer. Sublay mesh placement is superior to onlay and underlay placement in terms of recurrence and surgical site infection rates. Question. What recurrence rates have been reported for open Rives stopper repair? Answer. Recent studies report recurrence rates ranging from 7% to 11%. Preperitoneal sublay repair. Question. What is preperitoneal sublay repair? Answer. Preperitoneal sublay repair is a sublay technique in which mesh is placed in the preperitoneal plane rather than the retrorectus plane. Question. What are the advantages of the preperitoneal plane? Answer. The preperitoneal plane is not limited by the semilunar line and is less anatomically altering than retrorectus repair. Question. What is the main disadvantage of the preperitoneal plane? Answer. It is technically challenging because the peritoneum is thin and difficult to dissect. Question. What are the main operative steps in open preperitoneal sublay repair? Answer. The operation involves laparotomy, reduction of hernia contents, lysis of adhesions, and development of the preperitoneal space. Question. How is the mesh placed and how is closure performed in preperitoneal sublay repair? Answer. The mesh is cut to size and placed in the preperitoneal space with optional fixation. The peritoneal flap is closed, and the anterior rectus fascia is closed with a running slowly absorbable suture. Bridging or inlay repair. Question. What is bridging or inlay repair? Answer. Bridging or inlay repair is used when the facial edges of a hernia defect cannot be primarily closed and mesh must bridge the gap. Question. What are the main steps in bridging repair? Answer. The operation involves reducing hernia contents, lysing adhesions, and closing the fascia as much as possible before sewing mesh to the facial edges with a running suture when further closure would create undue tension. Question. When is bridging repair typically used? Answer. It is used in extremely large defects where facial approximation is impossible, including reoperative hernia surgery, emergencies, abdominal compartment syndrome, and traumatic tissue loss. Question. What are the outcomes and limitations of bridging repair? Answer. Bridging repair is associated with poor outcomes, including high recurrence rates and poor functional results, because it does not restore the linea alba. Even so, it may improve quality of life compared with the preoperative state and may be the only feasible option in some cases. Question. What principle should guide the use of bridging repair? Answer. Facial reapposition should be prioritized whenever possible, and bridging repair should be reserved for cases in which closure cannot be achieved. Onlay repair. Question. What is onlay repair? Answer. Onlay repair is a technique in which mesh is placed anterior to the anterior rectus sheath after reduction of the hernia sac, secured with suture, and covered with skin flaps. Question. What is the main advantage of onlay repair? Answer. Its main advantage is that the mesh remains outside the abdominal cavity, which can be useful in patients at high risk of future laparotomies. Question. What are the disadvantages of onlay repair? Answer. Onlay repair is associated with high rates of surgical site occurrences, infections, and hernia recurrence. Component separation. Question. What is component separation? Answer. Component separation is a surgical technique that creates myofacial advancement flaps to help medialize the rectus muscles and achieve primary facial closure. Question. What are the main types of component separation? Answer. The main types are anterior component separation, which divides the external oblique muscles, and posterior component separation, which divides the transversus abdominis muscles. Question. When is component separation indicated? Answer. It is used when the linea alba cannot be reapproximated because of a large hernia defect. External oblique release. Anterior component separation. Question. What is anterior component separation? Answer. Anterior component separation is a procedure in which the external oblique fascia and musculature are divided to increase abdominal wall mobility. Question. Who first described anterior component separation, and what degree of release can it provide? Answer. It was first described in 1990 by Ramirez Ramirez and colleagues, and it can provide approximately 3 to 10 centimeters of release per side. Question: what are the main steps in open anterior component separation? Answer: open anterior component separation involves laparotomy, reduction of hernia contents, lysis of adhesions, development of subcutaneous flaps, incision of the external oblique aponeurosis, and division of the external oblique muscle fibers to create space between the external and internal oblique muscles. Question: how does anterior component separation help close larger defects? Answer: incision of the posterior rectus sheath allows further medialization of the rectus muscles and helps close larger defects. Question: what modifications of anterior component separation are available? Answer: modifications include periumbilical perforator sparing techniques, external oblique release through separate incisions, and endoscopic release. Question: what is the periumbilical perforator sparing technique? Answer: this technique preserves the periumbilical perforators within a 3 cm radius around the umbilicus during anterior component separation. Question: what is endoscopic component separation? Answer: endoscopic component separation uses small incisions, balloon dissection, and trocar placement to visualize and divide the external oblique muscle with less soft tissue disruption. Question: what is the current role of anterior component separation? Answer: although it initially reduced recurrence rates in large ventral hernias, it has fallen somewhat out of favor because of high wound complication rates and the development of posterior component separation techniques. Transversus Abdominis Release. Posterior component separation. Question: what is Transversus Abdominis Release, also known as posterior component separation? Answer: Transversus Abdominis Release is a posterior component separation technique that extends retrorectus dissection beyond the linea semilunaris and increases facial medialization. Question: who developed Transversus Abdominis Release and when was it introduced? Answer: it was developed by Nowitzki and colleagues in 2012. Question: what are the advantages of Transversus Abdominis Release? Answer: it allows for up to 8 centimeters of medialization, avoids the large skin flaps associated with surgical site infections, permits wide retromuscular sublay mesh placement, and can be performed through minimally invasive approaches. Question: how is the operation performed? Answer: after developing the retrorectus space to the linea semilunaris, the posterior lamella of the internal oblique and the underlying transversus abdominis muscle fibers are divided medial to the linea semilunaris. Question: what technical point is essential during the dissection? Answer: the surgeon must identify and maintain the correct pretransversalis or preperitoneal plane throughout the procedure to avoid complications. Question: how are closure and mesh placement completed in Transversus Abdominis Release? Answer: the posterior layer is closed with a running slowly absorbable suture. The mesh is placed in the retromuscular sublay plane with wide overlap, and fixation is optional. Question: how effective is Transversus Abdominis Release? Answer: reported recurrence rates are under 5%. Question: what are the limitations or concerns of Transversus Abdominis Release? Answer: the technique requires access to the retrorectus plane, may be complicated by previous operations or anatomic variation, and performing it after anterior component release is controversial because of the risk of destabilizing the abdominal wall. Minimally invasive approaches to ventral hernia repair. Question: what is the role of minimally invasive surgery in ventral hernia repair? Answer: minimally invasive surgery is increasingly common in ventral hernia repair and abdominal wall reconstruction because it can reduce wound complications and shorten hospital stay in appropriately selected patients. Question: what additional knowledge is required for minimally invasive hernia repair? Answer: although the fundamental operative steps remain similar to open surgery, minimally invasive repair requires specialized knowledge of patient positioning, instrumentation, trocar placement, and potential complications. Question: what is important about trocar placement in minimally invasive surgery? Answer: effective triangulation of the target area is crucial. In robotic surgery, port placement can be more flexible because ergonomic limitations are reduced. Question: which trocars are often preferred and why? Answer: radially expanding blunt tip trocars are often preferred because they may reduce tissue trauma and bleeding, although upsizing may be needed for mesh deployment. Question: what intraoperative complications can occur during minimally invasive ventral hernia repair? Answer: accidental bowel injury or serosal injury can occur and may require conversion to an open operation. Question: what operative step can improve outcomes before mesh placement? Answer: closure of the hernia defect before mesh placement can reduce recurrence, bulging, and seroma formation. Intraperitoneal underlay repair. Question: what is minimally invasive intraperitoneal underlay mesh repair? Answer: it is a widely used minimally invasive technique in which mesh is placed intraperitoneally because the method is relatively straightforward and has a shorter learning curve. Question: what are the benefits of this minimally invasive approach? Answer: it offers the general benefits of minimally invasive surgery, including fewer surgical site infections and shorter hospital stays. Question: how are ports commonly placed for this technique? Answer: surgeons often use a triangulation approach, placing ports along the side of the patient to improve mobility and avoid the linea semilunaris, which helps reduce port site hernia risk. Question: what are the basic operative steps? Answer: herniated contents are reduced, the posterior fascia is cleared of adipose tissue to promote mesh apposition, and the defect is ideally closed before mesh placement. Question: why is defect closure preferred in this approach? Answer: closing the defect reduces pseudo-recurrence, which occurs when the mesh bulges through the original defect. Question: how is the mesh fixed and what type of mesh is used? Answer: fixation may be achieved with tacks or transfascial sutures, both of which may increase postoperative pain, and a composite mesh with an anti-adhesive barrier is used to reduce adhesions and bowel erosion. Question: what should be done with larger port sites? Answer: port site closure is essential when 10 mm ports are used to reduce the risk of port site hernias. Transabdominal preperitoneal repair. Question: what is minimally invasive transabdominal preperitoneal repair? Answer: it is a minimally invasive technique designed to overcome some limitations of intraperitoneal underlay repair, particularly the use of intraperitoneal mesh and the need for coated mesh. Question: how does the technique compare with intraperitoneal underlay repair? Answer: port placement and defect closure are similar, but this technique additionally requires preperitoneal dissection. Question: what makes preperitoneal dissection challenging? Answer: the peritoneum may be thin and difficult to dissect, especially in patients with previous operations. Question: where is the camera port typically placed? Answer: the camera port is typically placed about 15 centimeters away from the hernia defect. Question. What are the key operative steps in transabdominal preperitoneal repair? Answer. The herniated contents are reduced. The preperitoneal space is developed. The plane between the peritoneum and the posterior rectus sheath is dissected. The defect is closed with absorbable suture. The mesh is secured. And the peritoneal flap is closed. Subcutaneous onlay repair. Question. What is minimally invasive subcutaneous onlay repair, also known as the SCOLA procedure? Answer. It is a minimally invasive approach used to repair diastasis and small midline hernias, especially in patients who do not require dermal lipectomy. Question. How does the traditional repair of diastasis differ from the SCOLA procedure? Answer. Traditional repair usually involves a transverse lower abdominal incision, plication, and removal of excess skin, whereas the SCOLA procedure offers a minimally invasive alternative. Question. How are the ports placed in the SCOLA procedure? Answer. 3 ports are placed along the pfan and steel incision line. The midline suprapubic port is 11 mm, and the lateral ports are 5 mm. Question. What are the main operative steps in subcutaneous onlay repair? Answer. Dissection proceeds to the anterior aponeurosis of the rectus abdominis muscle. The umbilical stalk is transected and recreated during closure. The hernia sac is opened and reduced. The defect is closed, and the diastasis recti is plicated. Question. How is mesh used in the SCOLA procedure? Answer. Polypropylene mesh is placed in the onlay position to reduce recurrence risk and is secured with glue, sutures, or tacks. Question. What complications may occur after minimally invasive subcutaneous onlay repair? Answer. Reported complications include seroma formation, recurrence, and wound infection. Question. Which patients are best suited for the SCOLA procedure? Answer. It may be appropriate for carefully selected patients with small hernias measuring less than 4 cm and diastasis measuring less than 4 cm. Retrorectus sublay repair. Question. When is minimally invasive retrorectus sublay repair most applicable? Answer. It is suitable for larger midline hernias measuring about 4 to 8 cm or for hernias associated with diastasis. Question. How does the minimally invasive rive stopper repair compare with the open approach? Answer. It follows the same basic principles as the open approach, but the incision location and operative setup vary. Question. What factors determine incision placement for minimally invasive retrorectus repair? Answer. Incision placement depends on hernia location, rectus abdominis width, and nearby bony prominences. Question. What surgical approaches can be used for minimally invasive retrorectus repair? Answer. Retromuscular repair can be performed through a transabdominal or an extraperitoneal approach, depending on patient factors. Question. How should the patient be positioned for this operation? Answer. The patient is positioned supine with flexion to increase working room and to help prevent robotic arm collision. Question. What is the main limitation of the retrorectus space? Answer. It is limited laterally by the linea semilunaris, and further lateral space generally requires transversus abdominis release. Question. What is the enhanced view totally extraperitoneal approach? Answer. It is an approach that begins with direct access to the retrorectus space and uses a crossover maneuver to connect the bilateral retrorectus spaces. Question. What is a contraindication to the enhanced view totally extraperitoneal approach? Answer. A. If a pubic incision that has significantly disrupted the midline preperitoneal space is a contraindication. Question. How is the optical entry and crossover maneuver performed? Answer. The optical port is advanced through the rectus muscle and stopped just superficial to the posterior rectus sheath. The posterior rectus sheath is then incised on its medial aspect, approximately 0.5 centimeters from the linea alba, to avoid iatrogenic injury. Dissection then crosses the midline, clears adipose tissue from the falciform or umbilical ligaments as needed, and opens the contralateral posterior rectus sheath to expose the opposite rectus muscle. Question. How are the defect and mesh managed in minimally invasive retrorectus repair? Answer. The hernia defects are reduced, the retrorectus space is developed, and the defects are closed with suture. The linea alba may be plicated to address diastasis. The posterior rectus sheaths are approximated, and a medium-weight macroporous polypropylene mesh is placed after the space is deflated. Transversus Abdominis Release. Question. Which patients are candidates for minimally invasive transversus abdominis release? Answer. Candidates generally include patients with hernia defect 6 to 14 centimeters wide and no more than 20% intra-abdominal domain loss. Question. When is minimally invasive transversus abdominis release especially useful? Answer. It is especially useful for hernias in which retrorectus repair alone would not provide adequate mesh overlap or for defects extending lateral to the linea semilunaris. Question. Can redundant or atrophic skin be addressed in this approach? Answer. Yes. Atrophic skin can be removed after the minimally invasive portion of the procedure is completed. Question. How is access obtained for minimally invasive transversus abdominis release? Answer. Access in pneumoperitoneum can be achieved using a Verres needle, optical entry, or an open cut-down technique. Question. What are the early dissection steps in minimally invasive transversus abdominis release? Answer. The operation includes lysis of adhesions, posterior rectus sheath release, and blunt dissection superficial to the posterior rectus sheath. Question. How is the transversus abdominis release initiated? Answer. The release begins by dividing the posterior lamella of the internal oblique, followed by the transversus abdominis muscle or aponeurosis. Question. How is the release carried out anatomically? Answer. The release is performed from the subxiphoid space, curves inferiorly and medially, remains below the costal margin, and stays medial to the neurovascular fibers. At the upper abdominal wall, only the transversus abdominis is divided where its muscular contribution is most prominent. Question. What structures are exposed during the dissection? Answer. The transversalis fascia and peritoneal layer are dissected off the transversus abdominis muscle, exposing the diaphragm fibers and the myopectineal orifices. Question. How much advancement can be achieved with this technique? Answer. The posterior flap can advance up to 10 centimeters or more medially, and the anterior flap receives substantial advancement because of the dual facial releases. Question. How are the mesh and facial layers hernias managed at the end of the operation? Answer. Uncoated mesh is trimmed to size and placed in the retromuscular space. The anterior layer is then closed, often after reducing pneumoperitoneum to 5 to 7 millimeters of mercury, and the posterior flaps are reapproximated in the midline with a running suture. Anterior component separation question. Can anterior component separation be performed using a minimally invasive approach? Answer. Yes. Anterior component separation can be performed using a minimally invasive approach. Question. How is the minimally invasive anterior component separation typically performed? Answer. The surgeon usually inserts ports on one side along the linea semilunaris and performs the ipsilateral dissection first. After completing that release, additional ports are placed on the opposite side. Question. What must be visualized during the minimally invasive technique? Answer. The technique requires visualization of the entire anterior rectus sheath and identification of the linea semilunaris. Question. How is the release performed? Answer. A facial incision is made lateral to the semilunar line, followed by blunt dissection of the external oblique muscle to gain access to the internal oblique muscle. Question. How is mesh managed in minimally invasive anterior component separation? Answer. Mesh is inserted and deployed flush against the anterior fascia and usually requires fixation with sutures to prevent migration. Question. What postoperative considerations apply after this procedure? Answer. Subcutaneous drainage is typically used, and although less common than in open surgery, flap ischemia and wound infection can still occur. Selection of operative technique question. Why does operative planning for ventral hernia repair require an individualized approach? Answer. Hernia disease is complex and is influenced by factors such as location, size, patient health, and previous operations. Because no single classification system covers every situation, operative planning must be tailored to the individual patient and should include preoperative optimization, procedural selection, and postoperative care. Question. What expertise is required to choose the best operative technique? Answer. Surgeons need a deep understanding of abdominal wall anatomy, abdominal wall function, and the full range of operative techniques in order to minimize complications and choose the most appropriate repair. Question. Which patient factors should be considered when selecting an operative technique? Answer. Important factors include sex, body mass index, social history, smoking status, functional status, and medical comorbidities. Question. How can sex influence outcomes after hernia repair? Answer. Female sex has been identified as an independent risk factor for worse outcomes after hernia repair, including a higher likelihood of adverse outcomes and chronic pain. Question. What hernia management considerations apply to women planning future pregnancy? Answer. For asymptomatic or mildly symptomatic hernias, definitive repair is often delayed until family planning is complete. If repair is needed before pregnancy, primary closure may be preferred despite a higher recurrence risk, and complex abdominal wall reconstruction is generally avoided because it may reduce abdominal wall compliance. Question. When should a ventral hernia be repaired urgently? Answer. Hernias causing discomfort, pain, or obstructive symptoms generally warrant repair. Acute incarceration requires urgent surgery, and strangulated hernias require surgical exploration. Question. How should the surgeon think about repair when bowel compromise is present? Answer. If bowel compromise requires resection, primary repair is generally recommended because of the risk of mesh infection. If there is no bowel compromise, definitive repair may be considered based on hernia features and patient factors. In the acute setting, complex reconstruction with component separation is usually avoided, and primary repair, bridging repair, or even skin closure alone may be used as a temporary strategy until the patient can be better optimized. Question. How should diastasis recti influence operative planning? Answer. There is no absolute consensus on management, but diastasis recti may contribute to abdominal wall dysfunction, pain, and impaired core engagement. It should be considered during abdominal wall reconstruction and is a recognized risk factor for recurrence after hernia repair. Question. When is suture repair reasonable, and when is mesh preferred? Answer. Suture repair may be reasonable for small primary hernias measuring 2 centimeters or less. Although diastasis recti increases recurrence risk, mesh is generally preferred for primary hernias larger than 2 centimeters and for incisional hernias. Question. When is a minimally invasive approach preferred, and when is an open approach preferred? Answer. Minimally invasive surgery is generally preferred because it is associated with lower wound complication rates and shorter hospital stays, especially in more complex cases. An open approach is favored for small suture repairs or when extensive tissue manipulation is needed, such as with large facial defects, dense adhesions, or bowel resection. Question. How does hernia size influence the choice of repair? Answer. Size and anatomy strongly influence the choice of repair. For defects measuring about 2 to 5 centimeters, preperitoneal, intraperitoneal, or retromuscular mesh repair may be appropriate. Defects of 6 to 8 centimeters may require component separation with ribstop or retrorectus repair. Defects of 8 to 12 centimeters may require ribstop repair with possible transversus abdominis release, and hernias measuring 12 to 15 centimeters often require component separation. Question. Which anatomic details help predict whether facial closure is possible? Answer. Important details include rectus abdominis width, hernia location, the ratio of hernia size to neck size, and abdominal wall compliance. A ratio of total rectus width to defect width greater than 2 predicts a higher likelihood of successful facial closure with retrorectus dissection alone. Question. How should recurrent hernias be approached based on the prior repair? Answer. Recurrence after primary repair should generally be treated as an incisional hernia with mesh-based repair. Recurrence after mesh repair should usually be addressed in a different plane from the previous repair. Small recurrences after retromuscular repair may be treated with onlay or underlay repair, whereas larger or more complex recurrences may require redo retromuscular repair. Question. How should recurrent hernias with active infection be managed? Answer. A staged approach is recommended. The first stage focuses on source control by removing all foreign material, including sutures and mesh. Definitive repair is usually delayed for at least 6 months after the infection has been cleared. Complications question. What types of complications can occur after ventral hernia repair? Answer. Complications can be divided into early postoperative complications, which are often similar to wound complications, and long-term complications, such as chronic pain and hernia recurrence. Question. How significant are these complications clinically? Answer. Their clinical significance varies greatly depending on the specific complication and the patient's overall condition. Question. What does this section focus on? Answer. This section focuses on complications that may occur after ventral hernia repair. Infection question. What is a surgical site infection in ventral hernia repair? Answer. A surgical site infection is a complication caused by infection at the surgical incision site or from an intra-abdominal process. Question. What are examples of surgical site infections? Answer. Examples include abscess, necrotizing soft tissue infection, anastomotic failure, and mesh infection. Question. How are surgical site infections classified? Answer. They are classified by location and by the interventions required for resolution. Question. How common are surgical site infections after ventral hernia repair? Answer. Rates are highly variable and range from 4% to 21%. Question. Why are surgical site infections important? Answer. They increase the risk of hernia recurrence and can lead to chronic wounds. Question. Why is mesh infection particularly challenging? Answer. Mesh infection is a difficult problem that often requires reoperation. Question. What is an abscess? Answer. An abscess is a space-occupying collection of pus surrounded by inflammatory tissue. Question. How do superficial and deep abscesses present? Answer. Superficial abscesses may present with swelling, fever, purulent drainage, and pain. Deep or organ space abscesses may present with pain, fever, prolonged ileus, leukocytosis, and thrombocytosis. Question. What can happen if an abscess is left untreated? Answer. Untreated abscesses can lead to systemic infection, necrotizing soft tissue infection, wound dehiscence, and mesh colonization. Question. What is the most effective treatment for an abscess? Answer. Drainage is the most effective treatment, although small abscesses may sometimes be treated with antibiotics. Question. How long should antibiotics continue after source control for intra-abdominal infection? Answer. Antibiotics can usually be stopped 4 days after source control has been achieved. Question. Is routine follow-up imaging always necessary after treatment? Answer. Routine follow-up imaging is not clearly indicated, but worsening symptoms or laboratory markers may justify repeat investigation. Question. How common is mesh infection? Answer. Reported incidence ranges from 1% to 8%, and it may be underreported because diagnosis can be delayed. Question. When can mesh infection present? Answer. Mesh infection can be diagnosed up to 1 year after surgery, and some cases present even later. Question. How can mesh infection present clinically? Answer. It may present as a chronic draining sinus, recurrent seroma, enterocutaneous fistula, exposed mesh, abscess, skin induration, or pain. Question. What are the risk factors for mesh infection? Answer. Risk factors include diabetes, smoking, obesity, urgent surgery, and immunosuppressive use. Seroma question. What is a seroma? Answer. A seroma is a sterile collection of inflammatory fluid. Question. How common is seroma formation after hernia surgery? Answer. It is common, with reported rates ranging from 3% to 52.4% depending on the technique used. Question. What increases the risk of seroma? Answer. Risk factors include emergency surgery, high body mass index, large skin flaps, component separation, onlay mesh placement, and biologic mesh use. Question. How is seroma managed? Answer. Small, asymptomatic seromas are usually observed, while larger or symptomatic seromas may require aspiration. Question. How is aspiration typically performed? Answer. Aspiration is usually performed in the outpatient setting and may require repeated sessions or drain placement. Question. When is surgery considered for seroma? Answer. Surgery may be considered for seromas that do not respond to percutaneous treatment. Question. What role do drains play in preventing seroma? Answer. Drains are often used to reduce seroma formation, although they may raise concern about infection. A meta-analysis suggests they can reduce seroma without increasing infection risk. Question. When should drains be removed? Answer. Drains are generally removed when output remains minimal for 2 to 3 days or at a predetermined post-operative time. Hematoma question. What is a hematoma? Answer. A hematoma is a collection of blood within a surgical space. Question. How can a hematoma present? Answer. It may present with hemodynamic compromise, pain, swelling, or orthostatic symptoms, but some hematomas are clinically silent. Question. What increases the risk of hematoma? Answer. Risk factors include subcutaneous or intraparietal dissection, perioperative therapeutic anticoagulation, and component separation. Question. How is hematoma managed? Answer. Patients with hemodynamic compromise require resuscitation and may need reoperation. Stable patients with detectable bleeding may need imaging and observation. Question. When does a hematoma require reoperation? Answer. Reoperation may be necessary if the hematoma interferes with mesh incorporation or creates a high risk of infection. Question. How are minimally symptomatic hematomas managed? Answer. Minimally symptomatic hematomas can usually be observed. Chronic pain question. What is chronic pain after ventral hernia repair? Answer. Chronic pain is pain that persists for at least 1 year after ventral hernia repair surgery. Question. How common is chronic pain after ventral hernia repair? Answer. Approximately 25% of patients experience chronic pain after ventral hernia repair. Question. What are the risk factors for chronic pain? Answer. Risk factors include younger age, female sex, preoperative narcotic use, a high preoperative pain score, and early postoperative pain. Question. What should patients be told about postoperative pain? Answer. Patients should be informed that postoperative pain may last for months, and nonsteroidal anti-inflammatory drugs can be helpful during the initial months. Question. How should chronic pain be evaluated if it persists beyond 1 year? Answer. A thorough evaluation should include physical examination, imaging review, and correlation with surgical findings in order to identify any potential surgical cause. Question. What treatments can be considered for suspected neuropathic pain? Answer. Gabapentin or pregabalin can be considered when neuropathic pain is suspected. Question. Can mesh contribute to chronic pain? Answer. Yes, mesh can contribute to chronic pain, although it is difficult to predict whether mesh removal will improve symptoms. Question. What is a major risk of mesh explantation for pain? Answer. Mesh explantation can lead to hernia recurrence. Question. How should chronic pain be managed if no surgical cause is found? Answer. If no surgical cause is identified, the patient should be referred to a pain specialist, and options such as regional anesthesia, cryoablation, physiotherapy, and cognitive therapy should be explored. Intraparietal hernia. Question. What is an intraparietal hernia? Answer. An intraparietal hernia is a herniation within the layers of the abdominal wall, such as through the peritoneum or the posterior rectus sheath. Question. What can cause an intraparietal hernia? Answer. A traditional example is a Spigelian hernia, but intraparietal hernias are also becoming more common after retrorectus and component separation procedures. Question. How does an intraparietal hernia usually present? Answer. It often presents insidiously with vague or intermittent crampy abdominal pain and sometimes bowel obstruction. Question. Why is imaging review important after surgery? Answer. Surgeons should review cross-sectional images to identify the position of the mesh relative to the bowel, because apparently normal anatomy does not always exclude a hernia. Question. Why is intraparietal hernia clinically important after retromuscular repair? Answer. It is a rare but important complication of retromuscular hernia repair that can occur because of posterior layer dehiscence and usually requires operative intervention. Question. How can an intraparietal hernia be treated? Answer. Minimally invasive techniques may be used to reduce the hernia and repair the defect, with underlay mesh reinforcement if necessary. Abdominal compartment syndrome. Question. What is intraabdominal hypertension? Answer. Intraabdominal hypertension is defined as an intraabdominal pressure exceeding 12 millimeters of mercury, and it may occur during large hernia repairs. Question. What is abdominal compartment syndrome? Answer. Abdominal compartment syndrome is a life-threatening condition with organ dysfunction that is diagnosed when intraabdominal pressure rises above 20 millimeters of mercury. Question. How serious is abdominal compartment syndrome? Answer. It is extremely serious, with a mortality rate that can reach 60%, which makes early diagnosis and prevention essential. Question. How is abdominal compartment syndrome classified? Answer. The World Society of the Abdominal Compartment Syndrome recognizes it as a distinct form of compartment syndrome, called quaternary compartment syndrome. Question. What are the risk factors for abdominal compartment syndrome? Answer. Risk factors include positive fluid balance, hypoproteinemia, a high hernia sac to abdominal cavity volume ratio, and elevated body mass index. Question. How is abdominal compartment syndrome treated? Answer. Decompressive laparotomy is the traditional treatment, although quaternary compartment syndrome can sometimes be managed without surgery. Question. What postoperative care may be required in high-risk cases? Answer. Patients may require intubation, sedation, paralysis, and close monitoring of abdominal pressure after surgery. Question. Where should high-risk hernias with domain loss be repaired? Answer. Large hernias with domain loss should be repaired in a setting with intensive care unit access because of the risk of abdominal compartment syndrome. Venous thromboembolism. Question. Why are patients undergoing ventral hernia repair at risk of venous thromboembolism? Answer. Patients undergoing ventral hernia repair are at high risk of thromboembolic complications. Question. When should chemical prophylaxis for deep vein thrombosis begin? Answer. Postoperative chemical prophylaxis for deep vein thrombosis should be started as soon as possible. Question. How should symptoms of deep vein thrombosis or pulmonary embolism be handled? Answer. Any signs or symptoms of deep vein thrombosis or pulmonary embolism should be investigated promptly. Special considerations. Recurrence. Question. What is the typical recurrence rate after ventral hernia repair? Answer. The hernia recurrence rate generally ranges from 15% to 40%. Question. What preoperative factors increase the risk of recurrence? Answer. Important preoperative risk factors include smoking, diabetes, chronic obstructive pulmonary disease, American Society of Anesthesiologists grade 3 to 4 status, steroid use, and higher body mass index. Question. Why can weight loss be difficult before hernia repair? Answer. Weight loss can be difficult because hernia symptoms often limit physical activity, while delaying surgery may increase the risk of incarceration or strangulation. Question. How do postoperative surgical site occurrences affect recurrence risk? Answer. Postoperative surgical site occurrences, including infections, seromas, hematomas, and wound dehiscence, are associated with an increased risk of recurrence. Question. How does body mass index influence surgical site infection risk? Answer. The risk of surgical site infection rises as body mass index increases, with the highest risk reported in patients whose body mass index exceeds 42 kilograms per square meter. Question. How can minimally invasive surgery influence recurrence-related complications? Answer. Minimally invasive surgery may reduce complications such as surgical site occurrences because it uses smaller incisions and causes less tissue disruption. Question. How does smoking affect wound healing? Answer. Smoking impairs wound healing by reducing oxygen delivery to tissues. Question. What is the benefit of smoking cessation before surgery? Answer. Stopping smoking 4 weeks before surgery can reduce the risk of surgical site infection. Question. How are recurrent hernias increasingly managed? Answer. Patients with recurrent hernias are increasingly referred to multidisciplinary centers for comprehensive care, skin, soft tissue, and dead space management in abdominal wall reconstruction. Question. Why should abdominal wall reconstruction address the skin and soft tissue as well as the hernia defect? Answer. A complete repair should address both the hernia defect and the overlying skin and subcutaneous tissue in order to improve overall outcomes. Question. Why should excess skin be removed in selected cases? Answer. Excess skin may be excised to reduce the risk of seroma formation, skin breakdown, and infection. Question. What must be considered during paniculectomy? Answer. Excessive undermining during paniculectomy can compromise tissue vascularity, particularly in patients with previous abdominal operations. Question. How can small superficial wounds be managed? Answer. Small superficial wounds may heal by secondary intention with daily dressing changes. Question. What options are available for larger clean wounds? Answer. Large clean granulating wounds may benefit from skin grafts or flaps, and in rare cases regional muscular or fasciocutaneous flaps may be considered. Question. What are the benefits of negative pressure wound therapy? Answer. Negative pressure wound therapy can improve blood flow, promote granulation tissue formation, decrease contamination, and reduce wound healing complications when used over closed incisions. Question. How can fluid accumulation in dead space be managed? Answer. Layered progressive sutures, closed suction drains, and negative pressure wound therapy can all be used to manage dead space and reduce fluid accumulation. Question. Why is fluid accumulation important to prevent? Answer. Fluid accumulation can interfere with mesh incorporation and increase the risk of mesh infection and seroma formation. Acute presentation question. When is ventral hernia repair elective and when is it urgent? Answer. Elective repair is appropriate for reducible or chronically incarcerated ventral hernias with minimal symptoms, whereas urgent intervention is required for acutely incarcerated or strangulated hernias. Question. What symptoms suggest an emergency presentation? Answer. Emergency features include acute pain, nausea, vomiting, skin changes, fever, an elevated white blood cell count, and raised lactate levels. Question. How is a strangulated ventral hernia diagnosed? Answer. Diagnosis begins with the history and physical examination, while laboratory and imaging studies can provide additional support. Question. What are the main surgical goals in acute presentation? Answer. The goals are to relieve bowel obstruction and to resect any necrotic bowel or damaged tissue when necessary. Question. How does wound classification influence mesh use in acute hernia repair? Answer. In Class 1 wounds with intestinal obstruction but no strangulation or bowel resection, synthetic mesh is recommended. In Class 2 wounds with strangulated bowel requiring resection but without gross enteric contamination, mesh may still be used because it does not appear to increase short-term wound morbidity and may reduce recurrence. In Class 3 and Class 4 wounds with bowel necrosis or perforation, primary repair is generally preferred, and in very large hernia skin closure alone may be the only immediate option. Traumatic abdominal wall hernias and the open abdomen question. What is a traumatic abdominal wall hernia? Answer. A traumatic abdominal wall hernia is a rare injury caused by blunt force trauma that disrupts the abdominal wall. Question. How common are traumatic abdominal wall hernias and where do they occur? Answer. They account for about 0.1% of blunt trauma cases and may occur in the lumbar, flank, or ventral regions of the abdomen. Question. How does associated bowel injury affect timing of repair? Answer. In many cases, associated bowel injury requires immediate laparotomy, which complicates the timing of hernia repair. Question. How do early and late repairs compare? Answer. Early repair is usually performed during the index hospitalization, often within 48 hours, whereas late repair is performed after discharge and often includes mesh placement. Reported recurrence rates are similar between the two approaches. Question. What is an open abdomen? Answer. An open abdomen is a situation in which the abdominal wall fascia is not reapproximated after laparotomy. Question. Why might the abdomen be left open? Answer. The abdomen may be left open after damage control laparotomy, for treatment of abdominal compartment syndrome, or when a planned second look operation is needed. Question. What complications are associated with the open abdomen? Answer. Important complications include fluid and protein loss, fistula formation, vascular bleeding, and difficulty achieving later abdominal wall closure. Question. What temporary closure methods can be used for the open abdomen? Answer. Temporary closure options include simple skin closure, non-permeable membranes, and negative pressure dressings. Negative pressure systems help prevent facial edge retraction and may improve the chances of later facial closure. Question. How is postoperative care managed in patients with an open abdomen? Answer. Postoperative management usually requires intensive care and a multidisciplinary team. Question. When should abdominal closure be attempted? Answer. Timing depends on the reason the abdomen was left open and the patient's clinical status. In trauma, closure is ideally achieved within 48 hours if possible. Question. What options are available when primary closure is not possible? Answer. Options include negative pressure dressings, mesh bridging, and dynamic closure systems such as the abdominal reapproximation anchor system. Peristomal hernias question. How common are peristomal hernias? Answer. Peristomal hernias affect nearly half of patients who undergo ostomy creation. Question. Why is peristomal hernia management challenging? Answer. Management is difficult because recurrence rates are high and repair carries increased risks of surgical site infection and other complications. Question. What is often the best treatment option for a peristomal hernia? Answer. If feasible, ostomy reversal is often the best treatment because it addresses the underlying cause of the hernia. Question. What are the common repair techniques for peristomal hernia? Answer. Common techniques include the keyhole repair, in which the mesh has a slit for the ostomy conduit, and the sugar-baker repair, in which mesh is placed over a lateral east ostomy conduit. Question. What advantage does the sugar-baker repair offer? Answer. The sugar-baker repair is associated with lower recurrence rates than the keyhole repair. Question. What complications can occur when synthetic mesh contacts the bowel? Answer. Potential complications include erosion, obstruction, and other severe bowel-related problems. Loss of domain question. What is loss of domain in ventral hernia surgery? Answer. Loss of domain refers to large ventral hernias in which a substantial proportion of abdominal contents remains outside the abdominal cavity, creating functional problems and major reconstructive challenges. Question. How is loss of domain measured? Answer. It may be estimated using the Sabag formula, which compares hernia volume with total abdominal volume. A value of 20% or more suggests loss of domain. Question. How does loss of domain develop and what problems can it cause? Answer. It develops through chronic disruption of the linea alba, muscular atrophy, and progressive visceral protrusion. This can reduce intra-abdominal pressure, flatten the diaphragm, strain the spine, and contribute to venous stasis. Question. What preoperative optimization is important in loss of domain cases? Answer. Important measures include smoking cessation, nutritional optimization, blood glucose control, and improvement of cardiovascular fitness. Question. How can the volume of hernia contents be reduced before repair? Answer. Weight loss, omentectomy, colectomy, and selected small bowel resections may reduce the volume of abdominal contents. Question. How can the abdominal cavity be expanded before reconstruction? Answer. Progressive pneumoperitoneum, with or without botulinum toxin injection, can increase abdominal cavity volume and make reconstruction more achievable. Cirrhosis question. How common are abdominal wall hernias in patients with cirrhosis? cirrhosis? Answer. Approximately 20 to 40% of patients with cirrhosis develop abdominal wall hernias. Question. Why is hernia repair in patients with cirrhosis high risk? Answer. Emergency hernia repair in patients with cirrhosis is associated with high morbidity and mortality. Question. When is elective repair recommended for patients with cirrhosis? Answer. Elective repair is generally recommended for patients with model for end-stage liver disease scores of 20 or less, ideally in high-volume hepatobiliary centers. Question. Why is preoperative optimization essential in cirrhosis? Answer. Careful optimization helps reduce perioperative risk and improves the likelihood of a successful elective repair. Question. What specialist input is important before elective surgery in cirrhosis? Answer. Early hepatology consultation is important to assess the severity of liver disease and guide perioperative planning. Question. How is ascites managed before hernia repair in cirrhosis? Answer. Ascites may be managed with diuretics, large volume paracentesis, or transjugular intrahepatic portosystemic shunting. That concludes today's review of ventral hernias. Thank you for listening. We hope this question and answer discussion has helped clarify the anatomy, diagnosis, operative strategies, complications, and special considerations involved in ventral hernia management. Join us again for another surgical discussion.